Here are my declarations. Here are my declarations, they're available online for those of you who are interested. And I would just say that we're starting a study in Cape Town in Uganda on dolutegravir in pregnancy, which is funded by ViiV. Okay, so some figures to start with. Around 1.5 million HIV-positive women fall pregnant every year. And clearly, there's a risk of mother-child transmission, which varies from survey to survey. In sub-Saharan Africa, around 1 in 3, potentially risk transmission, vertical transmission. Despite ARV rollout, over 100,000 new infections in children in 2015, data from UNAIDS. And in 2015, global policy changed from either just option B or B plus to a clear preference for lifelong ART with option B plus. We know that coverage of antiretroviral therapy is high in pregnant women in sub-Saharan Africa. 2/3 of pregnant women who are positive are covered with ART, which is much higher than non-pregnant adults, and certainly higher than children. This year was interesting because there are now 4 countries where MTCT has been eliminated. In Cuba, 2015, Thailand, Belarus, and Armenia, 2016. But elsewhere in the world, it still remains high. And UNAIDS have set some ambitious targets for reducing the vertical transmissions to less than 40,000 by 2018 and less than 20,000 by 2020. And there's been a shift in our prevention targets to place MTCT reduction in the context of better health for mothers overall. That's nutrition, that's welfare, that's other co-infections, sexual health, malaria, all the rest of it, okay? There's much been written about risk of mother-child transmission. There are long lists. Some are disputed, maternal role of BV, role of STIs and HSV2 and all that. But clearly the 2 factors that come out again and again and again are the key determinants, which are maternal viral load at delivery and a persistent ongoing risk with breastfeeding, mostly in the early part of breastfeeding as well, okay? And data from the breastfeeding suggests that that the breast milk viral load is a reasonable, not perfect, but reasonable surrogate for risk of transmission. And I'll talk more about that later on. So maternal viral load at delivery and breastfeeding and possibly breast milk viral load. Why do we want to know about pharmacology in pregnancy? So first of all, with regard to the mother, and the changes in maternal exposure in the 3rd trimester particularly, and the question there is, how do we optimize the dose of antiretroviral therapy in the mother, particularly in the 3rd trimester? And then in antepartum, we also want to know how much the baby sees, and the surrogate for that usually is the cord maternal plasma ratio, or sometimes the amniotic fluid maternal plasma ratio. And the reason that we want to know that is that we want to know how much antiretroviral drugs the baby sees. That's both a good thing and a bad thing. So it's a bad thing if you're thinking about a child who's uninfected but seeing lots of antiretroviral therapy in a time that there is organogenesis. So there's some concerns, for example, about cardiotoxicity and AZT or mitochondrial toxicity and nucleosides and things like that. But it may be a good thing because actually if you can load the baby through the mother in pregnancy, actually that's a good way of giving the baby either PrEP or even PEP, actually. And so there are certain high-risk pregnancy scenarios, which we'll talk about later on, where you might want to deliberately load the baby up through the mother. We also want to know what happens in PK in the mother postpartum. And particularly, we want to know how much drug gets into breast milk, and of that drug into breast milk, how much gets absorbed in the baby. And again, that might be a good or a bad thing, because the baby, again, throughout breastfeeding, is getting exposed to antiretroviral drugs. But arguably, we know that the baby's getting exposed to HIV as well in many cases. So knowledge of that is important. you could go to any talk about antiretroviral pregnancy shows a silhouette of a pregnant woman with all the physiological changes, and this is no different. Many things happen to you in pregnancy. Total body water increases, renal blood flow, liver blood flow increases, there's changes to GFR, there's changes to gastric pH, gastric emptying, and also the effect mainly of progesterones is to upregulate mostly and downregulate certain liver enzymes. So CYP3A and 2D6 is increased. CYP2B6 not very much, because 2B6 is not a very inducible enzyme, so hence rifampicin hasn't got that much of an effect against efavirenz compared to other drugs. Progesterones also decrease, they also increase rather transporter expression, and they increase glucuronidation, UGT1A1 activity. But the story doesn't just end there, because there are also clinical changes. Things happen to you which are not necessarily around physiology. So, for example, there's much more vomiting, hyperemesis. So if you have drugs with food intake, that's an issue. If you have drugs with fasting, that's also an issue. There's more acid reflux, and therefore, particularly in third trimester, more use of PPIs, okay? More use of antacids. There's cholestasis of late pregnancy. So if you've got someone who's on atazanavir goes a bit yellow, you don't know whether this is an issue around cholestasis or an issue around drug. There are dysglycemias, and then there's a lot of use of iron and vitamin supplementation. So those of us who look after pregnant women will be giving them raltegravir while the midwife is happily giving them multivitamins and iron supplementation. So I've tried to summarize here the effects on AUC of various antiretrovirals by class, and the sample size is generally depicted by the square. So a square around this size indicates about 30 to 40 pregnant women in the third trimester. Okay, and if you look at this by class, the NRTIs are not significantly affected, so reduced maybe about 20%. The NNRTI is not much at all, and efavirenz, certainly with the 2B6, not much at all. The Nevirapine a little bit more, but not significantly. The integrase inhibitors likewise, so about a 30% reduction in AUCs, but we know that the integrases by and large can tolerate a 30% reduction, certainly raltegravir and dolutegravir. So again, a modest reduction. The issue comes with the protease inhibitors, and particularly with the protease inhibitors, you can see that actually there's a difference between the old formulations of lopinavir and the newer formulations of lopinavir, which are more bioavailable, so they compensate for that reduction by increasing it. Okay? But the main issues are around darunavir and atazanavir. So, if you look at darunavir first, so this is a look across a number of studies which have looked at the exposure of darunavir in the third trimester, both once daily and twice daily. And you can see that for once daily darunavir, the trough is lower. And the impact on the trough is even more than in twice daily during pregnancy. So, for example, you can see from the US studies or the PANA network, it's about a 40% reduction in the AUC of darunavir in the third trimester of pregnancy compared to postpartum, and slightly less of an impact in twice a day. And so, faced with this same set of data, two regulatory agencies, the US and the EU, made two completely different recommendations. So, and it's not the first time that's happened. So the US says in third trimester, all pregnant women should go into twice daily darunavir, whereas the EU have said there are many considerations in a pregnant woman, and pill burden is one of them, adherence is another one. So basically, there's a bit more leeway. So for example, if you were someone who didn't have any prior PI-associated resistance mutations, and you were durably suppressed throughout your first two trimesters, then it would be regarded as not unreasonable to carry on. Okay, so there's a debate going on here. Interestingly, I would make two other points. One is that actually cobicistat, there's no data on that, and you cannot assume that's the same because cobicistat, darunavir cobicistat has a similar Cmax to Darunavir, ritonavir, but a lower semen. So with cobicistate, you've already got a lower semen, and you add pregnancy onto that, that's going to be even more complicated. So I would say that actually I would have real concerns about that, I think, in pregnancy, given the lack of current data. CROI this year, there was a poster looking at increasing Darunavir to 800, 100 BD, not a hugely appreciable effect compared to 600, 100 BID, and it's quite a burden for pregnant mums to take. So what are the recommendations? Generally, standard dosing for NNRTIs and NRTIs and integrase inhibitors. Not much data on dolutegravir, but I'll show you some data in a while. And with lopinavir, standard dosing. With darunavir, BID dosing, possibly once a day in certain people. With atazanavir, the recommendation is 400, 100, accepting that there is actually a higher risk of hyperbilirubinemia if you do increase your level of atazanavir. But in patients taking atazanavir, tenofovir, maybe that's quite a reasonable thing to do. Okay, so that's what happens at PK in a mother in the third trimester. What happens in antepartum? Well, how much drug does the baby see? Okay, so the placenta is a pretty busy affair. It's obviously got physical barrier to drugs getting across. So a major determinant of how drugs cross the placenta is protein binding. Drugs which are highly protein bound don't generally tend to get across. But it's more than that. The placenta is awash with drug transporters, which the baby has put out to keep rubbish from the mother out of its system, and it's also awash with drug metabolizing enzymes and with UGT, with UGT1A1. So there is glucuronidase activity within the placenta. And I will group these. So PIs, as you expect, don't get across the placenta very well, and this is similar with what you see in the CNS and in the genital tract. Some PIs do better than others. Indinavir, not that we use it, is the least protein bound, so it crossed the most. Surprise, surprise. NNRTI slightly more, so about 50% gets across to the baby. So there is significant, and more so with nevirapine, there is a significant exposure. NRTI is generally pretty high, so what you get in a mother is generally what you get in a baby. And raltegravir is at least 100% and possibly higher. Some studies have shown threefold increase in cord blood. And dolutegravir, very little data, but again, and I will show you some data in a minute, very high, probably very similar to raltegravir in that respect. So this graph here, I've tried to summarize with a bold, line is the cord maternal plasma ratio. So, and in the shaded is the amniotic fluid maternal plasma ratio. So if you look at the NRTIs, they generally get across quite well. So if you've got a high-risk pregnancy and you want to, your mother seroconverts, or your mother presents a week before labor, or actually in labor, then you might want to, or multi-resistant drug, you might want to load the baby up. And generally speaking, NRTIs, raltegravir, and nevirapine are drugs that we generally use for that purpose. Okay, so NRTIs are pretty high. Amniotic fluid. Now, if you look at the NRTIs which are renally excreted, they tend to have very high amniotic maternal plasma ratio. And the reason is that the drugs get across the placenta, the baby then wheezes out the drugs and then swallows it back. And if you think that's disgusting, wait till they get out. And so you see... You see this effect in 3TC, but you don't in tenofovir, okay? You don't in tenofovir. And the reason is that the drugs have crossed the placenta as tenofovir, have been excreted as tenofovir and swallowed as tenofovir. We know that tenofovir is poorly bioavailable. That's why we have to give tenofovir as an alafenamide or a diproxyl fumarate. And so there's no intrauterine recycling of drug with tenofovir. Okay, NRTIs, modest, PIs, fairly little, and raltegravir, quite a lot. So here's a case report that a patient that we looked after, a 23-year-old woman initiating heart with multi-class resistance, so NRTI, NNRTI resistant, X4 virus, but no PI or integrase resistant. And like some of our women, unfortunately, we have to chase them around with midwives in the community, don't attend clinic, and poor adherence issues, which is how these arose in the first instance. So early at the end of the first trimester, started Darunavir once daily to try and deal with this adherence issue and make it acceptable, and dolutegravir, as well as nucleosides, failed to suppress, and in third trimester, entering the third trimester, Darunavir was doubled to BID, and dolutegravir was doubled to BID. And you can see the exposure of, in the first trimester, bold line, on dolutegravir once daily, and the dolutegravir exposure in the third trimester twice daily. So it does look as if the exposure to dolutegravir goes down in the third trimester. And interestingly, in this lady, we did suppress her in the end, the maternal cord blood ratio was in excess of 1. In other words, the baby sees as much dolutegravir as the mother did, at least as much. Okay? The impact P1026S study that was presented in CROI this year again showed pretty much the same. So 21 pregnant women given once daily dolutegravir, and the numbers were, these are preliminary data, so the numbers were low, but dolutegravir exposure did look like it was 30% down in the third trimester compared to postpartum. Okay. Maternal outcomes were reasonable, but there was some interesting debate around the fetal outcomes. So there were 10 babies were born at the time, and 4 of the infants had hypoglycemia, and there were 4 congenital anomalies noted, which was surprising, I think, to people. Now, some of these there was not much data around which gestation of exposure the drugs were, and causality. There was not much data. This has since been updated in a impact meeting, but the data are not in the public domain, and I think that there's a publication coming out. But suffice to say, I think the things that worried many of us, or would not worried, I think the things that we would look out for is this hypoglycemia and the polycystic kidney. So I think we need to look at these a little bit more closely as data emerge. Where do we get that data from? Antiviral Pregnancy Registry. That's a fantastic resource that's been going on since the days of AZT monotherapy in pregnancy. And it's been updated this year. And you can see that the prevalence rates are around 3% plus minus 1%. And that's true for all the old nucleosides except for DDI. And it's true for all the NRTIs. And there's no signal from integrases as a class, although that's mostly driven by raltegravir. Very little dolutegravir or elvitegravir data, and I cannot believe that there are only 29 women who've conceived on dolutegravir. So there's gross underreporting, and I would urge you, if you look after patients, to contribute data to the APR. So the drugs get across the placenta, and then they get into the baby, and the baby's born. So how long do the drugs hang around for in the baby? Now, raltegravir and dolutegravir are metabolized in whole or in part by glucuronidation, and glucuronidase activity is impaired in neonates. And you see that. So here's data from P1097, which is another impact study of 19 babies born to mothers who were given raltegravir. The cord maternal ratio is in excess of 1. There's highly variable elimination. But if you look at an adult half-life of 9 hours, the median half-life here was 26 hours, but with a half-life, the range going up to 184 hours. And I think there was some mention earlier on about pharmacogenetic effects. We know that people with UGT1A1 mutations, so Gilbert's disease, will have, in adults, in non-pregnant adults, will have higher exposure of raltegravir and also of dolutegravir, although not judged to be clinically significant. But of course, in these mothers, you might see an exaggerated performance because the mother is a poor metabolizer, so there's higher levels getting across to the baby. Then she also hands the baby the gene, so the baby can't get it out, and so the baby may get 2 hits in that scenario. So dolutegravir, preliminary data from P1026S. Again, typical adult half-life is 14 hours, and the half-life in these babies, in these neonates, was 35 hours, 34 and a half hours. So it's a very good way of priming the baby, but it does hang around for a fair while afterwards. Okay, so we've done the mother, we've done the cord blood. Now we're going to look at breastfeeding. So breastfeeding is an issue that actually most of the world is going to face, even though it's not done in developed countries. And the bottom line is that under optimal conditions in sub-Saharan Africa, certainly, you've got maternal heart, you've got antiretroviral protection throughout pregnancy. There is still a risk of residual transmission. It's much lower than the 30%. It's 3%, it may be less, but there's still a residual risk of transmission. And there are many reasons for that, but breastfeeding is certainly one of the big drivers for that risk. You all know the story about the risks, incremental risks from exclusive breastfeeding to mixed and bottle feeding. I said earlier on that breast milk viral load is a marker for transmission, so every log increase in breast milk viral load seemed to double the risk of mother-to-child transmission. An argument about role of mastitis seems to be important when you've got maternal viremia. Less clear what the role is if you're optimally suppressed in the mother. But the interesting thing here is cell-to-cell transmission in breastfeeding. Okay, so it may be important, particularly in early transmissions. If you look at infected breast milk cells, it's different whether you're talking about mature milk to colostrum. It's more in mature milk and less in fore milk and least in colostrum. Now, I said that there was a risk of residual transmission. So if you're breastfeeding and you deliver under optimal heart cover, okay, your risk of transmissions is dramatically reduced. But if you do transmit, the risks of having resistance is dramatically increased. Okay, so most people, of that small number who transmit, most of those will have some level of resistance. In the BAN study in Malawi, almost a third had multi-class resistance. So this is bad news if you transmit. And certainly a lot more work needs to be done to try and reduce these risks. There's some old data. This is a fairly old study from Tanzania prior to the rollout of widespread ART in pregnancy, which was nested within an RCT of vitamin supplementation. And so there were 61 mother-to-child transmissions. And so they went back, they looked at the breast milk and in the mother, and they also looked at the virus that was transmitted to those 61 children. And they did phylogenetic analysis. And to cut a long story short, if you look at the infant, if you look at phylogenetic analysis of the infant virus, it either mapped into three groups. Either it most closely resembled the maternal milk DNA, the maternal milk RNA, or you couldn't tell, there's a bit of this and a bit of that, okay? But they imputed from these two groups that actually in that infant probably got cell-to-cell transmission of virus, okay? And that infant probably got free virus in the milk, okay? And if you then looked at the time at which the baby was infected postpartum, they found actually an interesting association between early transmissions, and in early here was less than 9 months, but in fact most of the transmissions happened less than 6 months. Okay, that the early transmissions tended to be with cell-associated virus. So there's a lot of interest here, and there's a lot of interest also in breast milk DNA. And so people say, well, look, can we reduce the breastfeeding with early weaning? And there are a number of studies in this area. I'll just show you the Zambian early breastfeeding study, where there was a truncated abrupt weaning at less than 5 months versus continued breastfeeding. And basically, the mortality and morbidity was almost the same. And the reason is that early weaning reduced your HIV transmission, but increased your mortality through other non-HIV causes. So it more than offset each other. And that's not great news when you're talking about prevention. So WHO have recently, this year, produced new guidance, which is a strong recommendation for breastfeeding for at least 12 months under heart cover. And with a clear statement that actually mixed feeding is not a reason to stop breastfeeding. Mixed feeding may have greater risk, but in the presence of heart, it is possible to do that. Okay, so composition of milk. How long have I got? Right. Okay. So we're talking about breast milk. It's secreted through the breast milk alveoli. And essentially, you've got various pathways where you've got exocytotic secretion of proteins, okay, lactoferrins and all the rest of it, fat secretion through fat globules, transcytosis of immunoglobulins from mother to child, and then paracellular, which may be increased in various states of pregnancy and also with mastitis. Okay, so breast milk is a complicated affair. There are aqueous, cellular, and lipid fractions. Okay, and drugs partition differently. And so you can't assume that TAF and tenofovir will behave in the same way. There'll be more tenofovir getting into breast milk, presumably because there's more tenofovir in plasma, but it's not going to be absorbed, as I told you. TAF may be less, but it's going to be much more bioavailable. So we do need to understand these things if we're going to roll this out on. And the other thing, of course, is, you know, there's this drug in the breast milk, but is the baby actually going to absorb it? You know, and I just point out the fact that actually breast milk is awash with calcium, with iron, with magnesium. What's the effect of dolutegravir and raltegravir? We recently been validating some breast milk assays, and we noticed that actually recovery of dolutegravir from breast milk is increased by 30% if you collected in EDTA, for example, and sequester all the calcium into. So these are interesting findings and questions that need to be addressed. Katrina Waite, who's sitting over there, did recently a systematic analysis of breast milk penetration of antiretrovirals. You can't possibly read this, but I'll refer you to her article, which basically shows that NRTIs get across reasonably, and NRTIs so-so, and PIs badly, okay, as you would expect. I'm going to finish very soon. So with an issue around pharmacogenetics. So this is some work that we did with nursing Nigerian mothers. And so we genotyped them, and we looked at the maternal, so this is what the maternal efavirenz plasma concentrations are. So if you're a 2b6 poor metabolizer, you've got higher levels of efavirenz in your plasma than if you're a 2b6 wild type. This is not rocket science. Everybody's shown this, and it was good that we managed to replicate this. The interesting thing is if you look at the breast milk of those mothers, it's exactly the same. So that hierarchy of drug exposure also appears in the breast milk. And so presumably the babies of these mothers are drinking different amounts. So that baby from that mother is drinking much more efavirenz than that baby. But that baby is also developed, has also inherited an efavirenz poor metabolizer genotype from its mum, so it gets hit twice. And so you can look at the children, the infant efavirenz concentrations are high, nearly therapeutic levels in these babies as opposed to wild-type babies. So I think there are situations where pharmacogenetics has an impact not just on the primary mother, but also on the baby itself. Okay. To finish with, this is a problem in sub-Saharan Africa, that actually there is a lot of women who present in the third trimester. So this is data from the Guguletu cohort from Landon Myers' group, and you can see that it's bimodal. There's about 20% of patients who present in the third trimester of pregnancy with a new HIV diagnosis are going to start treatment late, may have high viral load, and actually with conventional therapy, you might not have a chance to get that viral load down to undetectable. And in fact, these data show exactly that. The later you start antiretroviral therapy, the higher the baseline viral load is, the less likely you're going to be undetectable at the time of delivery. And so that's going to impact on your risk of transmission, you would have thought. And there are good data that suggest that. The best study comes from China, looking at 1,500 positive pregnant women who start antiretroviral therapy in the first or second trimester, or else in the third trimester, 17% again, or else actually in delivery, which is about as late as you can start, really, and still being pregnant. And if you look at at the risk of getting infected, okay, in starting antiretroviral therapy in third trimester or in labor and delivery, it's sevenfold. You've got 700% higher risk of getting infected, of the mother infecting the baby with late initiation of antiretroviral therapy. If you look at the mortality, the infant mortality, it's doubled from 2% to 4%, okay? So this is a big deal. This is a big deal, and it's a big problem. And here I would argue there's a very strong reason to use integrases, because actually with efavirenz you may not have a chance in hell of getting that viral load down in time. And these are data from a retrospective US study, the HOPE study, looking at women who started, some of these were starting late, but not all of them. Some of them started in second trimester. These are women initiating heart or intensifying heart or switching heart in the presence of detectable viremia, okay? And there's 101 women, 39 were taking integrases, and you can see the mean time to 1 log drop in viral load was 8 days on an integrase and 35 days with an other drug. We know from non-pregnant women in the spring that so the median time to undetectable with dolutegravir was 28 days, and it was 84 days in the efavirenz arm. So actually, if you've got a third trimester, you've got high viral load, you really, I think, need to seriously think about using an integrase. Which integrase? So before we go on to that, WHO, as you know, changed its policy brief to put dolutegravir as an alternative first-line regimen. But the two things that stood in the way of widespread, clear recommendation for dolutegravir was pregnancy and HIV/TB co-infection. And pediatric data as well, okay? So those are forthcoming. What trials, I won't go into this, what trials are forthcoming on dolutegravir? I had a quick look at clinicaltrials.gov. There are PK studies, so Impact 1026 is continuing to report, so is the European PANA network. And there's a PK study which I'm involved in, and Katrina as well, Dolphin 1. There is the 336 study by ViiV, which is a rollover study from women recruited in other studies such as ARIA who become pregnant. Then there are two randomized control intervention efficacy and safety studies. So these are not primarily PK, sorry, that's a mistake. They're not primarily PK studies. These are big studies. And this slide is riddled with error, sorry. So Impact is around 500 patients, Dolphin is around 250 mothers, and they're going to be randomizing dolutegravir-containing regimens versus efavirenz or standard of care, and looking at transmission and safety. There's a similar study of raltegravir, NICHD P1081, which is looking at a similar thing with raltegravir versus efavirenz. But as you can see, there's much more data for raltegravir than there is for dolutegravir. So in summary, and I'll finish now, generally, antiretroviral therapy is a good thing. It's a life-saving thing. The antiviral pregnancy registry is a great resource. If you haven't contributed yet, please go online and do so. The decreased exposure in the third trimester may not be clinically relevant. In fact, it's probably not clinically relevant other than for certain PIs. I've made the point about late pregnancy. And I think I would make another point about the need for data early. So we were having a discussion about long-acting earlier on, and I just made a point that with lots of new drugs which are introduced, the pregnancy data sort of follows behind after they're licensed, about a year or 2 or 3 or 5 or sometimes even longer behind. With something like cabotegravir, where the drug is going to hang around for a year afterwards, actually we do need that data a bit sooner than that because you can bet that when cabotegravir is eventually licensed, women will become pregnant. So I'll finish by acknowledging all the various people who've helped me. Katrina Waite, particularly, currently in Uganda, Landon Myers and Catherine Orrell from Cape Town, Mohammed Lamord from Infectious Diseases Institute, Mark Morochnik, Polly Claydon, and Angela Kolbers. Thank you very much.